Thank you. So I'm going to go ahead and call to order the February 23rd meeting of the Human Services Subcommittee of the Finance and Ways and Means Committees. We are going to hear 10 budgets today related to the Department of Health and Human Services. I wanted to remind the public that there are multiple ways that you can participate. If you found us here, you've probably already been to the website. The legislative website has a help link at the top of every page. If you click on that link, it will tell you about how you can register for meetings and sign up to give comment. You can send us written testimony, or you can send your opinion in through an opinion poll. If you're having any challenges participating with the legislative session in any way, please reach out to the email that is on the agenda, and staff will help you to find your way. With that, we are going to move into, we have quite a number of budgets today, committee. We've got, I believe, 10 that we are going through. And so we're going to make sure that we get our questions answered, build in a public record on these budgets, but also try to move efficiently. So I'm going to ask your favor that if somebody's already asked your question, you can just say pass, and that we stay on the fiscal items, and remember that this is a finance committee, not a policy committee, and stay to the questions that are going to help us build the record on the fiscal side. So with that, I'd like to invite up the Department of Public and Behavioral Health to kick us off with budget 3153.
Good morning.
Good morning. How are you, Ms. Sherrick?
Good. We're just pulling, there we go. Okay, so my name is Lisa Sherrick. I'm the administrator for the Division of Public and Behavioral Health. Here with me today is Debbie Reynolds, Deputy Administrator for Administrative Services, Julia Peak, Deputy Administrator for Community Health Services, Margot Chappell, Deputy Administrator for Regulatory and Planning, and on the phone, we have Erin Williams, our Chief IT Manager. Moving to slide 2, it provides an overview. I'm sorry about this. Oh, I lost my slide. Oh, slide 2 provides an overview of our division's vision and mission. Slide 3 provides an overview of our division's organizational chart. I'd like to note on the chart that in addition to the sections overseen by the deputy administrators here today, the division has clinical leadership in the areas of medicine, epidemiology, and behavioral health.
I'm going to have to interrupt you because I was so enthusiastic about getting going that I completely missed doing roll call. So we're going to have to take a step back and take roll. So if you could just pause for a second, and staff, if you could help me with the roll.
Assemblywoman Benitez Thompson. Assemblywoman Carlton.
Here.
Assemblyman Frierson.
Here.
Assemblywoman Monroe Moreno.
Here.
Assemblyman Roberts.
Here.
Assemblywoman Titus.
Here.
Assemblywoman Tolles.
Here.
Assemblyman Watts.
Here.
Senator Canizero. Senator Don Daraloop. Senator Hammond.
Here.
Senator Kekeffer.
Here.
Chair Ratty.
Here. Please go ahead, Ms. Chair.
Okay, so continuing on slide 4 provides an overview of our agency operations. We are comprised of 5 service branches: community health, regulatory and planning, clinical, behavioral health policy, and administrative services. Slide 5 provides a snapshot of the division's requested funding for FY22 and 23. This includes general fund, which accounts for 36% of revenue over the biennium. federal funds, which account for 39% of revenue over the biennium, and other funds, which account for 25% of revenue over the biennium. Slide 6 provides our FY 22-23 biennium budget account summary. Our public health budget accounts, some of which will be covered today, are highlighted in green. Slide 7 provides an overview of COVID-19 funding received in our public health budget accounts, totaling over $416 million. As we all know, this past year has been unprecedented in doubling our operating budget without additional fiscal staff, and programmatic support has been beyond challenging. However, I would like to take a quick moment to thank all of the public health staff who have been working tirelessly over the past year addressing COVID. Of the $416 million, this includes over $321 million in federal grant funds awarded to DBPH. And it also includes over $95 million in CARES Relief Treasury funds, also known as CRF, authorized through the Governor's Finance Office. Slide 8 provides an overview of the same COVID-19 funding outlined on the previous slide, but broken down by the Federal Authorization Act. Slide 9 outlines position transfers to the Director's Office requested in multiple budget accounts to merge all data analytics in one budget account for department-wide standardization. Because this involves 17 FTEs for DBPH, we felt it made the most sense to group these transfers on one slide rather than discussing within each individual budget. With that being said, we are happy to answer any questions related to these transfers now.
Thank you. I know on this budget, I have a question from Senator Dondero Liu. Would like to start?
Thank you very much, and thank you for that information. I have a couple questions. Is this division confident that the quality of data that we're receiving from that Nevada Central Cancer Registry will remain the same if the fee increases is ultimately implemented?
Julia Peak for the record. Thank you for that question. I would absolutely, I'll say, and I just want to acknowledge all the efforts of both our providers and our staff. This is the first year that we've been able to meet a gold standard certification. The last time we saw this happen was 2005. And so based on the work we've been doing this biennium, not only do we have the number of cases that we need with the staff that you provided us in the first year of the biennium, that 2 FTEs, we were able to get all the cases abstracted, cleaned, and sent to our federal partners. So what we've proposed right here with the new fee schedule will get the registry where they need to be in perpetuity.
Thank you for that information. And just as a follow-up, Madam Chair, based on the projected cancer cases and the amount of staff time each case requires, would you give us a little more information on how the agency determined its need for 2 additional health program specialists?
Yeah, absolutely. Julia Peak for the record. I'll go ahead and start this one. Don't know if my colleagues have more to add, but so,
Julia, if I may, sorry, this is Lisa Sherrick. Would you prefer to answer these during this director office transfer or 3153, the cancer registry budget? I'm sorry, I probably wasn't clear that these transfers are not part of 3153.
Oh, okay. Well, if you would.
So, yeah, I'll jump in. That was thank you for clearing up the confusion because I was having a hard time tracking as well. So I thought we were jumping in with 3153, but looks like you had some introductory remarks. So anybody have any questions on the introductory remarks or the transfer?
If I could ask a clarifying question, I think she said the transfer were in budgets 32. Sorry, the slide went away. So I want to make sure I have the budget that they were referencing correct. And so I need those 4 digits again.
150.
For the record, this is Debbie Reynolds, Deputy Administrator. The transfers to the Director's Office involve multiple budget accounts. It involves a transfer from the Cancer Registry 3153, as well as the Bureau of Health Prevention and Wellness, budget account 3170, Immunization Program 3213, Healthcare Quality and Compliance 3216, Office of Epidemiology, budget account 3219, and also Maternal and Child Health budget account 3222. It involves 17 different FTEs in multiple budget accounts. That's why we grouped them on the one slide. I apologize. We thought it would be easier to do it that way rather than talking about within the individual budgets. But we do plan to talk about Cancer Registry next.
Okay. So does anybody have any questions on the 17 position transfers that come from multiple budgets?
Well, I guess I do, Chair, but do you want me to ask them within the context of the budget, or are we free to ask those all now?
I think if anybody has a general question about all of the transfers, we should ask it now. If it's a specific question to that budget, we'll ask it when we get to the budget.
Okay. So I guess the one thing that I noticed with the budget transfer that I'll probably talk a little bit more, I guess, as we get into those budgets, are kind of some of the federal corresponding the federal dollars and state dollars that go along with them. On some of them, it looked like, especially in the transfers to the new analytic office, it made the numbers just seemed odd of the number of FTEs we were pulling over, and I guess why more federal dollars weren't following them. It looked like it was just staff dollars and not really operational dollars. That was, I guess, if we're talking about transfers, the biggest question I had.
Julia Pink, for the record, I can answer that one if you'd like me to do that now. Thank you, Chair. So the way we looked at the transfers, it is highly federal funding. As you all know, public health is almost entirely federally funded, with a rare exception of a few programs that get some general fund support. So these programs were within 3219 primarily, but you see the other budgets accounts associated as well. They were doing analytics work under the supervision of our state biostatistician. And most of our federal funding, again, you all know this, but I'll just put it on the record, it goes to staffing and pass-throughs to our local partners. So when you say that it's primarily the staffing that's being moved, that's absolutely a true statement. That's primarily what we fund at DPBH, is the staffing, and then a little bit of operations as far as rent and any IT expenses and those kind of things. So it's just pooling that position, putting it directly under the chief biostatistician formally on paper, and then taking those funds with them. As far as the operations, those will remain in the home budget accounts, and we'll continue to push those grant funds out to our local partners if they're available through our federal funding partners.
Madam Chair, I have a question on the positions, if I might, quickly.
Please do.
So this is regarding, it's something that I've seen, and we've asked this before in the committees, but for a specific example, I was going to wait until that budget, but in the budget that you're moving over, an agency in the Maternal Mortality Review Committee, for example, you're moving folks over at a higher grade because now you have contract folks. And again, if we need to discuss that during that budget, we can, but it just seems that globally, when you hire somebody in a new position, you're not starting them at step one. You seem to be bringing them over, not just you, but other departments, at a higher level. And in the past, we've heard that that's because this person's been there, and so it's that they know their job. Is that the case in this budget too, that you already have somebody that you're interested in moving over to that full-time position? But my question is, why don't you have somebody within the agency take that position and then hire somebody at a lower level? Why do you have to have that person that's been there? So I think that's my I need some more information on why you hire at these higher levels, step grades, as opposed to coming in at step one.
Thank you for the question, Debbie Reynolds, for the record. This particular transfer is an FTE of an existing position, and so the transfer would include the existing step. However, with regard to the contract position that we are converting to a state FTE in budget account 3222, we budgeted the position based on the allowable steps that are authorized to budget for. In this case, this grade of position would be authorized to budget for a grade step 7. That's really just a budgeting tool to allow appropriate authority to hire based on the necessary skills. It's not a guarantee that the incumbent would be hired at that step. That would be based on the qualifications of the individual candidate.
Great. Thank you. Thank you for that clarity. Thank you, Madam Chair.
You bet. All right, I'm going to move us on into the individual budgets. And if anybody has questions on transfers, they can do that in that individual budget. So moving on to, and apologize for the confusion, staff, let's, I believe you're going to go next to 3153. Is that correct? Cancer registry?
Yes, Lisa Sherrick for the record.
Great.
Slide 10, budget 3153 is an overview of the Nevada Central Cancer Registry, or NCCR. The goal of the NCCR is to collect comprehensive, timely, and accurate data of all incidences of cancer among Nevada residents. Slide 11, the Cancer Registry is funded 100% in other revenue, which includes a transfer in federal grant revenue in budget account 3220, transfer from DMV for license plate revenue, and fees for the abstraction of cancer data. E225 adds 2 Health Program Specialist 1 FTEs in the second year of the biennium to appropriately support resources needed to meet the demand and maintain national standards to secure continued federal funding and provide Nevada with quality cancer surveillance information. These positions will support abstraction of cases, training and quality assurance, and analysis and reporting of cancer data. I would like to highlight that the registry has struggled with staffing to the level needed due to funding challenges, but the 2 positions will get the registry to a place of success and sustainability. The 2 additional staff funded in the first year of the last biennium allowed our data to be certified as gold standard after many years of missing the mark. E226 establishes a fee of not more than 8% for the registration and renewal application of a radiation machine, mammography machine, healthcare facility, and medical laboratory to support the cancer registry. The language in the proposed BDR allows the division to charge up to 8%, but our intent is to only charge the amount necessary to support the cancer registry. Therefore, projected revenue in FY 22-23 is calculated based on a 6% increase in fees paid to the Radiation Control Program and Healthcare Quality and Compliance, or HCQC. That concludes the major enhancements in this budget. Does the committee have any questions?
I'm going to go ahead to Dr. Titus.
Thank you, Madam Chair. I appreciate the opportunity to ask a question on this one too. It got a little confusing there. Ms. Peak, you and I have had many, many discussions on this cancer registry and trying to solve it, keep it solvent and solve some problems and make sure that the goal of this is to make sure we get information in there. These 2 folks that you're going to hire, these additional folks, will they be actually entering the data into the system? We've spoken in the past that it's somewhat cumbersome. Offices don't get it done. And I'm just wondering if that's actually what they're going to be doing.
Thank you for the question, Julia. Keep for the record. Again, I appreciate your time over the many years of looking at this. So they could do a combination of many things. It could be working with a provider to send a faxed or paper record to us, and we could do that data entry. Hopefully that's less common. But again, totally an opportunity for the position should that need to occur with individual providers. We're also working hard to get the web application up so that providers' offices could enter via the web and then we could pull it. But again, many options for a provider to report. We just want to make it as easy as possible. I hope these positions will do similar to what they've been doing in the interim, and that they'll be taking the reports either through paper submission or through the electronic submission and developing the abstract, the quality needed to submit to our federal partners. So that's looking at the diagnostic information provided by one provider, looking at the treatment information provided by another, filling in the gaps where there are gaps. For example, if race ethnicity was missing, we have to do some work to try to pull that information and submit it to our federal partners. They have required variables. These positions could also provide training and technical assistance if needed, if a provider was struggling for whatever reason. They audit records to see if anything was missed. Again, not to be punitive, but to figure out why that case was missed and make sure we count it. This registry, I'll just say, is very unique in that with communicable disease reporting, we report what comes to us up to our federal partners, where with the cancer registry, our federal partners say, we expect Nevada to submit 15,000 cancer reports, and you have to submit those reports to a certain level of quality. And if you miss the mark on that, then they say you missed cases and therefore wouldn't get gold standard. Probably more detail than you needed, but I just wanted to say that it's a very unique program, and these positions will need to be flexible as they have been in the interim. But it's absolutely a resource for providers, be it from training to data entry to analysis, whatever that looks like.
Okay, so in summary, then the goal is to actually make sure we can arise to the federal requirements for cancer registry, gather good information. But my concern is that we don't want to be penalizing the providers who give this information and discourage them for sharing this information if it costs them more money. So at the end of the day, we'll need reassurance that it's not going to discourage patients from or providers from participating because it will cost them money. So thank you for trying to tease all this out. I think it's incredibly important that we get this information. So thank you, Madam Chair, for the extra question.
Assemblyman Roberts.
Thank you, Madam Chair. A quick follow-up to Assemblywoman Titus is regarding the two positions. And you mentioned a backlog in here of entry. And will this facilitate, or are you caught up? And will this help you eliminate the backlog with these two additional positions?
Julia Peak, for the record, I'll go ahead and answer that one. The way the cancer report works is we have a natural delay in getting the data. So for example, we got a gold standard certification when we submitted our 2019 data. I believe it was a year prior for the actual year it was reported. So that's to say we don't have a backlog in the current reporting year. We are analyzing the data as it comes in to report. We have the option, should we have staffing time and ability, to go back and submit prior years. As I mentioned earlier, 2005 was the last year we got gold standard. So if we had time and cases to abstract from prior years, we can go back and try again and submit more cases. But our priority will be to ensure that we, going forward, get every case entered. And then at the time we do the call for data, which is what the federal partners call it, that record is fully up to date for that calendar year, and we have no backlog. These two FTEs, as I mentioned, were able to pull that off in the year that we reported.
And just quick follow-up. And so the fee increases are necessary to support these two positions and some?
Julia Peak, for the record, we're trying not to get it with the and some. We're trying to hit the nail right on the head so that we don't charge our providers more than necessary. But yes, okay. The two FTE were able to abstract the number of cases that our federal partners had put as our goal amount.
Thank you. Thank you, Madam Chair.
Senator Hammond.
Thank you, Madam Chair. The question I have is in regards to the governor's recommendation. We saw that they're worried about the solvency of the program, and so they asked that they find some way to increase some revenue or get some more money. And I saw that the first thing that what we see here is an increase in fees for mammography machines, healthcare facilities, and so forth. The only question I had was, were there other plans? I mean, obviously this plan worked. This is the plan that you guys accepted. Were there any other thoughts, any other plans that you guys wanted to put into action, try and raise those, raise the money, or did it go right to raising fees?
Julia Peak, for the record, just by way of giving a brief history, many years ago, the first time we took a stab at changing the NRS related to the cancer registry, that was a time when we were charging hospitals $8 per correctly reported case. And so that's how we were generating a fee, for lack of a better term, to support the registry. We went to the legislature and did a BDR and pulled that back so that if they reported properly, then we wouldn't charge them. Last year we came, I should say last session, we came to you and asked for a general fund to support these two positions. And we were encouraged, you provided us 1 year of that general fund and encouraged us through an LOI to look at all these different options. There were many options so that, if I got $1 for every version that we put forward and considered, we could probably fund the registry with that. But to say that this was the best option that we came forward, I do know there's an error in one of the budgets where it noted a $30 amount. That was another consideration that we had, is straight charge a $30 amount. But we decided that the more equitable and appropriate way to do the fee was to do it as a percentage to their annual fee charged through our licensing body, because what we saw is that some facilities have a very low operating budget, and to charge them $30 versus charging a large hospital $30 was probably not the most equitable way to do it. So again, out of all the versions we looked at, we thought that charging the smallest percent to their annual fee was going to be the least burdensome, because it would just be one annual fee to the agency and we would transfer accordingly, but also that it was an amount that was not fixed by a facility type, that it would be based on, again, their licensure fee.
Thank you so much. Thank you, Madam Chair. I appreciate it.
But I don't see any other questions on this budget. So team, please move on to the next budget.
Lisa Sherrick for the record. Slide 12, budget 3190 is the Office of Vital Records, or OVR. This program issues certified birth and death certificates, maintains and protects all vital records, and processes all legal corrections and amendments to these vital records. Additionally, OVR participates in the National Vital Statistics System and responds to the data and statistical needs of federal, state, and local agencies and researchers. Slide 13, health statistics and planning is funded 100% with other revenue, which includes fees and federal contracts. E805 requests to reclassify 5 existing Administrative Assistant 1 FTEs to Administrative Assistant 2 FTEs in the Office of Vital Records. This program experiences high turnover in full-time employees due to promoting to higher pay grades within the state when opportunities become available. With longevity being rare with these positions, it has impacted the ability of the program to complete the increasing demands from constituents. E550 is a request for a vital record system upgrade. OVR is mandated per NRS and NAC 440 to register birth and death records, issue birth and death certificates, and to complete amendments for paternities, adoptions, errors, and gender changes. The current system is outdated, difficult to use, and to modify mandated legal changes. That concludes the major enhancements in this budget. Does the committee have any questions?
Yes, Madam Chair, I have a question.
Great, thank you.
Thank you. So with that, gosh, this is kind of, in a way, a sad budget, because we realize what these folks have been through with what the pandemic has brought to this state. So could you just tell me a little bit about the workload, how much that's increased?
We'd have to get
Margo.
that to her. No, I do not have the workload.
Lisa Sherrick for the record. I actually do not have that information readily available, but happy to provide after this committee, if that's acceptable.
Thank you. We appreciate it. You know, whenever we see those numbers on the TV, sometimes I think of your folks having to deal with all that paperwork, how overwhelming it might be. So with the new system, hopefully it'll alleviate some of the issues. Do you see any anticipated fee increases with the new system, or is just the enhanced usage of the documents that need to be sent out going to cover the cost of this?
Okay. For the record, Debbie Reynolds. Based on the upgrades that we're looking to the existing system, existing fees are sufficient. However, that's not to say that ongoing in the future, there wouldn't be a need to increase fees for other reasons, or if additional enhancements are needed to the system.
Okay. Can you tell me what your turnaround time is on death records right now? Because We know on death certificates.
Lisa Sherrick for the record. According to staff, there's currently no backlog, but I would need to confirm that and provide information after this committee on the turnaround time.
Okay. Thank you. A backlog and turnaround time are two totally different things. Okay. All righty. Thank you, Madam Chair.
You bet. Assemblyman Roberts?
Thank you, Madam Chair. Real quick question. I see you're pulling 1.4 million from the reserves fund to support the tech advances. Is that going to deplete the reserve fund account? And is that fund healthy moving forward?
For the record, Debbie Reynolds. While the enhancements to the vital record system do use a significant amount of the reserves, it does not fully deplete the reserve levels. The required reserve in this account is, I believe it's, actually, I don't have it in front of me, but based on our reserve calculator, there is sufficient reserve at the end of the biennium.
You have an approximate? Is it like most of it, half of it? If you don't, I apologize. I don't want to put you on the spot. I can get it later. My concern was that you deplete the account and then we have to raise fees later on to build it back up for contingencies like this. But thank you. I'll get it offline, Madam Chair.
Thank you. Assemblywoman Tolles.
Yes, thank you so much, Chair. And my question is just, as we look at this new system, how well will it coordinate with the county systems and other state agencies? Just want to make sure that we have bridges built, that it's still easy to access. I know that there's approximately 4,000 users of this data across agencies.
We don't have that.
Lisa Sherrick for the record. My understanding is this upgrade will work with all the entities that use it and was taken into consideration when looking at this. But we could provide additional information after this committee if necessary for those specific details to each of the counties.
Great, thank you. I just know, having been in this business in the past, sometimes we implement something and then all of a sudden we get surprised with a bill later that we need to bridge the technology between various entities, and just want to make sure that we are already crossed that off of our list of concerns.
Chair, and if we may, Lisa Sherrick for the record, Debbie Reynolds does have the reserves information.
Thank you. Debbie Reynolds for the record. I apologize for the delay in responding. The minimum reserve level in this account is 120 days. And at the end of the biennium, we will exceed that minimum reserve level by 10 days, which equates to $681,168, which is adequate to run the program for 120 days, which is the minimum amount we need before additional revenues begin to be collected.
Thank you for the answer.
Do we have any additional questions on this budget? All right, seeing none, we'll move on to 3194, Environmental Health Services.
Lisa Sherrick for the record. Slide 14, budget 3194 is Environmental Health Services, or EHS. Environmental health involves those aspects of public health concerned with the factors and conditions in the environment or surroundings of people that can influence health and well-being. EHS conducts activities such as permitting, education, inspections, enforcement, and emergency response for the protection of public health. Slide 15. Environmental health services is mostly funded with other revenue, including license and fees, FDA food safety contract, and county reimbursements, as well as some federal revenue. E225, request to eliminate 3 FTEs, including 1 public health rating and survey officer, 1 environmental health specialist 3, and 1 administrative assistant 2 to meet revenue projections in the environmental health services program. That concludes the major enhancements in this budget. Does the committee have any questions?
Right, Assemblyman Watts, I believe you have a question.
Yes, thank you, Madam Chair. Could you explain if these cuts that the agency is included in the executive budget will allow them to have sufficient personnel to meet inspection needs over the upcoming biennium?
Good afternoon, good morning, Margot Chappell for the record. We hope so. It appears that we might. It's unpredictable whether some businesses that closed during the pandemic will reopen. We did not lose that much capacity during the pandemic, even though we had some bars and restaurants closed permanently. We do have new ones opening up, so that is slightly unpredictable.
Thank you, Ms. Chappell. Thank you, Madam Chair.
Assemblywoman Benitez Thompson.
Thank you, Madam Chairwoman. I have a question about the elimination of the 3 vacant positions. And I guess I'm wondering, knowing that you might, as we open up and the need for demand might change for these positions, I guess, would it make more sense to hold them vacant versus just eliminating them, which would only give you the only option of coming back next biennium to re-ask for the positions?
Thank you for the question, Debbie Reynolds, for the record. Certainly the ability to hold the positions would be helpful. And then if we need to request to fill them again, coming to IFC to request approval, we would be happy to do that.
I appreciate that. Thank you.
Thank you for the question. Assemblywoman Titus.
Thank you, Madam Chair. Just to be clear, these positions really are, this department is the one that goes out to the rural areas and all the counties who do not have their own food inspection personnel. Is that not correct? So,
Chappell, for the record, that is correct.
All right, so I'm curious, because Clark has their own, Marshall, Carson, and Douglas, all the other counties rely on the state to send these folks out. If they want to open again and be inspected, it's going to be up to the state to help them get there. So my question really is, do you currently have a waiting list when somebody asks you to come out and they're trying to get open, they need to be inspected, or there's a complaint? What's the timeline between that call or the request and you getting somebody out there?
Margot Chappell, for the record, we have had no delay during the pandemic, partly because we did delay some regular inspections and we've been prioritizing complaints and initial licenses.
So what, from the time somebody makes a call, whether for services or not, how long does it take to get the person from the state there? 1 day, 2 day, immediately? What does it take?
Margot Chappell, for the record, it's very close to immediately once we have the entire application completed, but I will get that information more specifically and get back to you about the timelines related to that.
Great, because as Assemblywoman Benitez Thompson mentioned, there many restaurants are closed and then we're trying to get open. Hopefully we get them all open. There may be a mad rush to get that inspection, and I just want to make sure we can get Nevada back open as quickly as possible when that time happens. So thank you for that. Thank you, Madam Chair.
Welcome. All right, I don't see any additional questions on this budget. So if we can move on to 3213, the immunization program.
Lisa Sherrick, for the record, slide 16, budget 3213 is the immunization program, which administers the federal Vaccines for Children program, develops and promotes maternal and adult immunization education programs, maintains the statewide immunization information system, develops state immunization and vaccine preventable disease regulations and laws, maintains a quality assurance program for county health districts, public health clinics, and private physicians who administer state supplied vaccines. They also oversee the statewide immunization registry, otherwise known as WebIZ. Slide 17. The immunization program is funded with general fund, which is primarily used to purchase needed vaccines as the required non-federal match for the Nevada Checkup Program. Federal funds, including various federal grants, and other revenue, including various transfers. E225. This request converts one full-time contract position to one state full-time health program specialist 1 position needed to support the Vaccines for Children's program. The proposed position will serve as the immunization projects coordinator to coordinate and oversee adolescent and adult immunization programming and pandemic vaccine planning and related collaboration with Nevada's Emergency Preparedness Program. We know that this position is needed as a permanent state position, as it has been operating as a contract position for about 4 years. That concludes the major enhancements in this budget. Does the committee have any questions?
Assemblywoman Monroe-Moreno, would you kick off the questions on this budget, please?
Thank you, Madam Chair. I have a few questions, and thank you for the presentation and the work that you're doing in our communities. Could you explain to us just a little bit more? You know, the opening story on the news this morning is how Nevada is not getting the vaccines at the rates that other states are getting it. So it's kind of fitting to have this budget hearing today. Could you let us know how many Nevadans have received their first dose? How many have received their second, if you have those numbers? And how does Nevada compare with and respect to other states nationally where we're at? And then what are the main obstacles in the distribution of the vaccine in our state? And then I'll have another question after that.
Julia Peak, for the record, I'll go ahead and start. If I miss any of your questions, please ask them again. As far as the number of doses administered, we do have a dashboard now on the nvhealthresponse.nv.gov website. So I'm just going to go ahead and note the answer to the one you asked. Again, available by county on that dashboard. We are at 556,556 total doses reported administered. Again, a breakdown to more details available there. We, as I mentioned on our Health and Human Services presentation, but I'll say it again, we've consistently had the highest rates of administration in our region. The biggest challenge for us remains supply. The demand is so high, and also we have so many opportunities through our pharmacies, through our local partners to get vaccines in arms. We just do not have the vaccines to get those in arms. So we're ready when our federal partners are able to give us a greater allocation. We're going to start soon administering in more of our federally qualified health centers who are going to be getting the vaccine sent directly to them. So it's only growth in the future in this program. As far as news on Nevada not getting the allocation that we think we need, I'll just note that our federal representatives, as well as our governor's office and many local partners, have been reaching out on a regular basis, expressing our concern over our numbers. And we'll continue to be the squeaky wheel on that. But we do know our allocation is going up every week. We're thankful for that, and we'll get that in arms. We just, every state is suffering with a supply issue at this point. Did I miss any of your questions?
You did not. You actually answered what would be my follow-up question. I'm happy to hear that you're working with our federal delegation to get the rollout that we need in the state. And I believe you're looking at other larger sites like Allegiant Stadium to help push it in the south and other larger areas in the north if we are able to get the vaccines that we need. But the other thing I also wanted to just say is thank you for what you were doing with the flu vaccine. I know there was a huge push to get people vaccinated for the flu. Could you just give us a quick update of how that went?
Yeah, absolutely. I know we had also worked with the legislature, so I do want to acknowledge all of your efforts to try to get vaccinations up in your delegation. So we've been doing a lot with flu. We were worried prior to the season that we would have the combination of a respiratory virus season of influenza and COVID, and that would have overwhelmed our systems. And with everybody working so hard to get flu vaccination up, specifically in our adult population, it wasn't realized to the extent we thought it would be. I will note that Nevada has some of the lowest adult vaccination rates in the nation. So this is not something that we need to do as a onesie. This is something that we'll need to do in perpetuity with so much media and outreach and education related to vaccinations. I don't want to miss the opportunity while we're talking about COVID to talk about the various other vaccinations that our population can be getting to be healthier long-term, but a ton of effort again related to flu. So I want to acknowledge all our partners, but we have a lot more work to do, to be honest.
And just one more question, Madam Chair, if I can. When you mentioned the adolescents and other vaccines that our children need, are we on track? Did the pandemic interfere with parents getting their children the vaccines that they need on the time schedules that they need to have them?
Julian Peak, for the record, that has been a huge issue. And so we'll need to look at getting people, specifically our kids and teens, as you mentioned, into their primary care doc, or we may need to stand up pods and do it for our kids to make sure they get the vaccinations needed. All of us, including myself, have delayed some primary care visits just because of COVID. And so once we get more of the population vaccinated and get those folks back into their primary care providers for vaccination and screenings, that'll be a huge win for us. I do have some statistics just to provide really quickly. As far as our kindergartners, we're really at par with national standards. In some cases, we're just a slight percentage higher, but for the most part, we're specifically for teens, we're slightly lower than the national average of 71.5% of our teens having that vaccination. We're at 68.9%. So again, kind of at par with what the United States is as an average, but certainly more work to do in this area because that could prevent disease and outbreaks long term.
Thank you so much. And thank you, Madam Chair.
Thank you, Assemblywoman Titus.
Thank you, Madam Chair, and thank you again for all you're doing for the state. I don't think we say that enough to you. Real quick on these, on the WebIZ and our flu vaccines and our COVID vaccines, have we been able to keep up the data entry to making sure that we have that all loaded up onto WebIZ as folks get these vaccines?
Julia Peak, for the record, we've been working really hard. Flu, I would say, is not an issue. However, COVID is a challenge. So I'm happy to note that this week we rolled out our deployment of a Salesforce tool specifically for public health agencies and emergency managers who are interested in a tool. This tool will allow for us not to do dual data entry. So what we've had to do to this time is typically the public health agency would enter it into some sort of clinical record, and then they'd have to dual enter it into WebIZ. The Salesforce platform that we chose to purchase again for the state will do the automatic transfer of data to WebIZ so that dual data entry is not required. That said, there is still a backlog because we just deployed this week. So Clark County is vigorously working to get all of their data entry. And I don't think it's a large backlog anymore, but happy to provide that exact information.
Right, because as you are well know that all these different facilities have different EMRs. And so as they give them in these clinics, it's always been an issue of us trying to, when we give a vaccine in our office, trying to match that with WebIZ. And I just want to make sure we have that platform where as we're giving these vaccines, we can load it up to WebIZ from the regular EMRs and the provider's office. And whether or not now we're talking about veterinarians being able to give this vaccine, we're talking about dentists being able to give that vaccine. I just want to make sure we're not getting that cart, ahead of the horse and that people can upload that data. So please keep us apprised of that situation and how you're doing with that. That's really important. Thank you.
Senator Hammond. Senator Hammond?
Yep, there it is. I had to get rid of the screen. Okay, so the question I have is, with all the data coming in and the vaccine being rolled out, do you happen to have a rolling count of, percentage-wise, how each county is doing? Have you broken it down to each county? I can imagine that, like Eureka County, I hear is really high. They've got almost 35% of their population vaccinated for COVID-19. Do you know, is that accurate? And is there a count for some of the other counties? How are we doing?
Julia Peak, for the record, again, I would probably refer you to the dashboard. It's updated Monday, Wednesday, and Friday, and so it does have all the COVID vaccinations by county. We're also trying to track really solidly where they are according to the playbook, because as you know, one of the things that we've done is we have a call center who supports people across the state in booking vaccination. So it's really important that we know where each county is in the playbook. Where, as far as booking, as you know, this week we started for 65 plus. statewide. So it's a combination of looking at where they are in the playbook and then if they have any barriers to actually get vaccines in arms. But our state biostatistician and our vaccination team have done an excellent job on that dashboard to provide that information. It's also color coded by county to make it easier to follow. So I'm happy to provide the link to the committee, but instead of just reading through where they each are, it's probably easiest just to pull up on your screen. But
absolutely, thank you very much. Appreciate that.
Thank you. So, team, perhaps the multi-million-dollar question, which I know there's some fluidity around right now, but how are you feeling about having the resources necessary at the state and local public health infrastructure level for when that supply does open up to be able to complete the vaccine rollout?
Hi, Julia Peak for the record. I'll go ahead and take this one again. So when we looked at what we thought it would actually be as far as an expense to our public health and emergency management teams, we thought it would be close to $50 million to do this for the course of a year. As you know, we did get a grant from the Centers for Disease Control and Prevention that's closer to 28 million. And so we distributed that per capita and then a little to our state DPBH program. But one of the benefits is that our epidemiology and laboratory capacity grant, again, we're not on that budget account right now, but to answer your question, our federal partners have given us latitude in that funding stream because specifically it's written in the guidance that if we need to use that for vaccination efforts, as long as it's not duplicative to the vaccination grant or another federal funding stream. So the way we've looked at approaching vaccinations, again, if it's $50 million or more, we've looked at all the different budget accounts that could potentially go to vaccination, again, our priority focus right now. And we've asked the counties to prepare budgets looking across all the funding systems to support that. I'll also note that the most important thing is that it's easy for the individual resident to get vaccinated. So though we will stand up and support our big pods, there are many appointments available at Walgreens and Walmarts and your pharmacy where the state doesn't necessarily need to invest any dollars in that. The vaccination comes directly to Walgreens or Walmart, and all we do is assist individuals in booking that appointment. So it's a call center expense, but not an administration expense, for lack of a better term. So we are confident right now that we do have the funding necessary, at least for the duration of this year, to support what's needed as far as vaccinations. But we always get surprised with COVID. So that's not to say that we might need more funding, and we'll continue to advocate for that at through our federal delegation.
Great, thank you. It's a big lift. Again, I want to just pause and express the gratitude of the legislature to this team and all of the folks that you represent, who I know have been working long hours creatively and thrown some curveballs over and over again. You've done a tremendous job, and I know that we don't always see all the workings behind the scenes, but just wanted to take a moment. And I know this is true across everywhere, but in this particular issue, a lot of focus and a lot of attention, and we thank you. All right, let's go ahead and move on to 3216, healthcare facilities.
Lisa Sherrick for the record. Slide 18. Budget 3216, Healthcare Facilities Regulation, protects the safety and welfare of the public through regulation, licensing, and education. They maintain an agreement with the Federal Centers for Medicare and Medicaid Services, or CMS, and completes federal certification inspections for certain healthcare facilities and medical laboratories. They also issue licenses to certain allied health professionals. Slide 19. Healthcare quality and compliance is funded primarily with fees and other transfer revenue from Medicaid, as well as a small portion general fund to support certification and inspection of CBLA homes. ETT5 requests funding for 1 new health program specialist 2 and 3 new health program specialist 1 positions to support an infection control and prevention unit in order to proactively conduct infection control assessments within the licensed residential and long-term healthcare facilities. Over the past year, we recognized we needed to improve measures to prevent and control infections and quickly identified the need for this unit to specifically address infection control and prevention in facilities where Nevada's most vulnerable citizens reside, and foresee this need continuing in the ongoing future. Additionally, the staff are specifically infection preventionists who augment and work with HCQC inspectors on infection control, prevention, and intervention. As of yesterday, February 22nd, Nevada continues to be well below the national average of the percentage of deaths in facilities as it compares to total deaths, and we were at 14.7%. I continue to credit the hard work this team and HCQC staff have done to prioritize addressing infection control and prevention in Nevada facilities, which are evidenced by Nevada's numbers. E680 aligns revenue from general fund to fees for community-based living arrangements. Oh, and this one too, right? E681, slide 20, I apologize. E681 aligns revenue from general fund to fees for replacement equipment. That concludes the major enhancements in this budget. Does the committee have any questions?
I believe that Assemblywoman Benitez Thompson has some questions on this budget.
Thank you so much, Madam Chair. I appreciate that. And I think what I might do is just maybe put a couple of thoughts that I have in my head on the record. And then because of the interest of time, just know that it's some follow-up conversations that I would be interested in having with the division. And they're mostly around the community-based living arrangements. Last session, we had a couple of different efforts to address the backside of how we pay providers and some cleanup there, as well as the front end and inspections and those position transfers from HCQC. And so I guess I would say the governor's recommended change in here to, spend less than the general fund we gave you makes me a little bit nervous. And so I just want to be able to talk about that more and see if that is actually going to be our best way forward, or if there's some other considerations we might hold in mind. And that's all I'll put out there, Chair. Thank you.
Thank you. Assemblywoman Tolles.
Thank you so much, Chair, and thank you for this particular budget item in this recommendation. I had one of the skilled nursing facilities in my district was one of the hot spots with at one point, I think an 85% infection rate and 30 losses of life. And so I want to commend this unit because that was very, very, very early on in the pandemic, and the response from that point on, not just in that particular facility, but also statewide, to recognize how incredibly vulnerable these populations are and how necessary it is to really quadruple the efforts in terms of response to infection control was wonderful to see. So I really do want to commend you. And in regards to just some of the questions, it sounds like you definitely covered the need for this new unit, but if you could just specify a little bit more specifically what the activities and services are that you anticipate that this unit will engage in to help stop that infection spread in the future, I appreciate it.
This is Julia Peak. I'll go ahead and start. Just by way of some history with the infection control efforts we've done at the state related to this program and the combination with epidemiology. After the hepatitis C outbreak in Clark County, we developed a unit in our epidemiology unit working with our healthcare facility inspection team to do healthcare-associated infections to better respond to outbreaks in those facilities. So when COVID hit, Nevada was much more solidly positioned to be ready to respond. We already had the contacts, honestly, in the facilities when they had a GI or other outbreak. So I just want to acknowledge that we did have a structure in place that many states didn't, and our team worked really hard. That said, what we learned with COVID is that we can do better. And as you said, potentially quadruple the amount of effort. So I'll turn it over to my colleague to speak a little bit more about how she's going to build it in her unit, but we already had a pretty strong foundation to build upon.
Good morning, Margot Chappell for the record. Specifically, the activities they have been and will be conducting is conducting facility on-site visits and off-site reviews of infection control practices, performing risk assessment and assessing facility infection control programs, identifying gaps in facility infection control and prevention structures, processes, and outcome measures, performing situational analysis based on facility-specific risk, recommending the appropriate evidence-based interventions, such as those based on CDC guidelines. I have a pretty extensive list. Would you like me to read it or send it to you?
I think the chair would appreciate me answering that question with, please send it to the entire committee so that we can review it. And just to get these last couple questions on the record, I would assume that the obvious anticipated outcome is that we would just continue to see that good work of minimizing any kind of spread and infection. But one last question I do have is, how do we prioritize these facilities in terms of where we direct that attention first? Because I know you can't be in all places at once. We've seen when an outbreak takes over in one facility that can, in the past had erupted quickly. So how do you prioritize which ones and in which regions across the state you're going to focus your energy on?
Margot Chappell, for the record, thank you for the question. We look at, when we do the assessment, when I just mentioned the activity of the assessment, they look at what infection control practices are there and how many people have acquired the infection. And that's part of how they prioritize. So we look at the specificity of the severity, I should say, the specificity and the severity. And I'll turn it over to Julia to answer more of that thing.
Yeah, and I would also, Julia Peak for the record, the only thing I would add is that for all diseases, what we look at is based on the number of cases that they have, we work with them remotely in many cases initially and say, here are the infection control recommendations that we want to put in place. We then track the number of cases that they're reporting. If it appears that they're not administering that in the way we think is appropriate, meaning there's more spread than we would like to see based on that epidemiological curve, we will send staff out to figure out exactly what's happening. It might just be confusion with our recommendations. It could be they're using the wrong cleaning product. It could be a number of things, but that really prioritizes who gets an on-site visit. And also if they just come in with a huge number of cases in an initial report and we say something's wrong, then we'll again send staff out for that on-site inspection opportunity versus a more remote technical assistance. So it really varies, but it is that weekly assessment that we have as a team or an immediate response if we feel that there's really a critical issue at that specific facility.
Great. Thank you so much for the answer. Thanks for the time, Chair.
You're welcome. Wanted to jump in a little bit more on solvency. So it's a fee-based program, and it does look like you are expending more resources and starting to take down the reserve. Could you just talk about whether is this program solvent, and do you have any concerns?
Thank you for the question, Debbie Reynolds for the record. In this budget account, fees can be updated through regulation. Fees were last updated in 2010. The reason for the depletion of reserves is mainly due to the increase in salaries and COLAs, step increases, as well as a higher percentage of filled positions than in years past. We're also now hiring almost all health facility inspector RNs at step 10 and other health facility inspector generalists with superior qualifications at increased steps. We have seen an increase in the cost of category 1 salaries from FY20 through, prior to an increase from FY14 to FY20 in approximately, it's 54%, which equates to about $3 million increase in salaries over that time frame. I think that the program definitely needs to look at evaluating our workload and the fees necessary to support that workload. And we're happy to follow up and have additional discussions with your fiscal staff.
Great, thank you. I do think that that's important that we have those continuing conversations with our staff. So I appreciate the commitment to do so. And then Senator Dondero Liu.
Thank you very much, Madam Chair. These 8 positions, are you going to have the continuing need for all of those? to meet your workload in that community-based certifications and inspections?
Good afternoon. Good morning, Margot Chapel. For the record, we're not able to complete the workload analysis. When COVID hit, we were halfway through it, and so we would request additional time to review that to determine whether it's possible that some of those positions may not be necessary.
Thank you. And a follow-up to that, can you comment on whether those positions are doing work outside of the tasks associated with that? And if so, what kind of work are they doing?
Margot Chapel, for the record, again, they are, and that's why the general fund was reduced. We have been funding their salary when they do alternative inspections for residential facilities for groups, which is part of also the depleting fees and why we need to complete the workload analysis.
Thank you. And I echo the chair's responses. Your work is, I know, has been very, very hard the last year, and I appreciate that. This too is something that I have experienced within my district, having a facility that had an abundance of issues. So one last question, will you have sufficient resources, do you think, available for those inspections in the 21-23 biennium?
Margot Chapel, for the record, yes.
Thank you very much. And thank you, Madam Chair.
Thank you. And I'll just follow up. We started with Assemblywoman Benita Thompson, and I think that there's a lot of interest on the part of this committee that we don't go backwards on the CBLA inspections and making sure that we are protecting our most vulnerable citizens in those particular settings. Lots of progress made. And so I will just look forward to continuing that conversation with staff and getting that information back to the committee we're looking for some strong assurances that we're going to be able to continue that work moving forward. Let's go ahead then and move on to 3219 Biostatistics and Epidemiology.
Lisa Sherrick for the record, slide 21, budget 3219, the Biostatistics and Epidemiology budget account serves the Office of Public Health Investigations and Epidemiology, or otherwise known as OFI. OFI records and analyzes reportable disease information, conducts interviews with infected individuals and their contacts, refers individuals for medical treatment, analyzes data from disease investigations, identifies risk factors, provides education and recommendations on disease prevention, and works in conjunction with appropriate agencies to enforce communicable disease laws. Slide 22. E900 transfers the Human Immunodeficiency Virus Surveillance Program from the Communicable Disease Budget Account 3215. This transfer is requested because Centers for Disease Control, or CDC, merged the HIV surveillance and HIV prevention grants into a single award with shared deliverables, and to ensure that the programs was more closely integrated in all states, so Nevada made the decision to formally move them under one manager to support this federal push. Slide 23. The Office of Biostatistics and Epidemiology is funded primarily with numerous federal grants, state general fund to support the state epidemiologist and chief biostatistician in various program transfers. E902 transfers 2 disease control specialists from Community Health Services, budget account 3224, to better align duties of the positions. These positions support investigation of all reportable diseases in many of our rural and frontier counties. This requires them to review laboratory and clinical reports to identify infection, interview the case, identify and notify contacts, and address outbreaks in each community. E905 transfers the State System Development Initiative Grant, or SSDI, to the Maternal, Child, and Adolescent Services budget account 3222. The primary purpose of the SSDI grant is to develop, enhance, and expand state and jurisdictional Title V maternal and child health data capacity for its needs assessment and performance measure reporting in the Title V MCH block grant program. Slide 24, E680 and E681 reduces general fund with federal funds for equipment. That concludes the major enhancements in this budget. Does the committee have any questions?
Thank you for the presentation. I believe Assemblyman Watts has some questions to lead off.
Yes, thank you, Madam Chair. Going to your last slide for decision units E680 and E681, has the division confirmed that the federal agencies would not consider this shift from general funds to state funds supplanting and therefore not allowable?
Thank you for the question, Debbie Reynolds, for the record. As you all know, COVID has had a severe economic impact. We were required to put forward substantial general fund cuts to our public and behavioral health services. The majority of our general fund is on the behavioral health side. Fortunately, many of these cuts were restored by the governor. However, we do still have general fund, some limited general fund on the public health side. We tried to limit the impact to the direct services that we provide and to our staff who provide those services. We do not believe that this is supplanting because we were required to cut the general fund. We're not using the general fund on other activities in place of the federal fund. And therefore, this just results in less grant funds available for other activities, but it does not impact our ability to accomplish grant requirements or result in a direct reduction of services. That said, we don't have specific guidance from the federal funding entities that this particular reduction is not supplanting, but we do believe that we've made an appropriate decision based on the difficult decisions we had to cut the general fund.
Thank you for that clarification. And yes, I understand that these are very difficult decisions that we've had to make and working to try and preserve services wherever and whenever possible. The other question I had was on the transfer of the HIV surveillance program, decision unit E900. And I was just wondering, you discussed some of the how this aligns with federal initiatives. Could you also speak briefly to any benefits that the state will see in HIV prevention, treatment, and care by transferring this program back to the communicable diseases budget?
Julia Peak, for the record, I'll go ahead and start and then see if my colleagues have anything to add. But one of the things we look at with all our programs is who does the staff talk to most often? And in this case, we saw that our surveillance staff, especially when our federal partners merged the two programs, they were talking most often to our prevention and care teams versus our epidemiology teams. Again, we're still addressing any outbreaks in the community and interviewing cases out of our epidemiology unit. But the surveillance unit, their main role is to pool data and look at where there is risk to the community and provide that information to our prevention and care teams to direct resources and efforts. And so when we saw that there was opportunity to better integrate, again, with our federal partners seeing the same thing, we thought it best to physically move those staff under the same manager, just because it, again, we work across all programs, but having the same manager allows a level of oversight and integration that you don't get when you have programs in different locations. So again, when we looked at 3219 and said what programs perhaps could live better in a different budget account and under a different manager, we moved them accordingly. It started with the Office of Analytics. And then as you saw in the presentation, there's other small grants, our state systems development initiative for the maternal and child health program. That grant was better served in the maternal and child health program directly. So we just did that cleanly throughout 3219 and put those programs where they're best housed elsewhere throughout the division. But I'll also add pulling the disease investigators back to live under our state epidemiologist was a good decision as well. And so there's a little bit of swapping, but it has to do with their daily activities and how we can best serve that frontline staff and then ultimately serve the community.
Thank you for the clarification. I appreciate it. And it does provide some additional detail on the efficiencies that this transition would bring. Thank you, Madam Chair.
Thank you. I think we also have some I have some questions around laboratory testing and capacity. So obviously our state lab has been an integral part of our COVID-19 response. Could you just describe the lab and testing capacities and how they've been expanded with federal funds? Is that impacting the lab's ability to do other work? And do we have the capacity we need if there's another spike?
Yeah, Julia Peak for the record. I too want to acknowledge our Nevada State Public Health Lab and the other labs in our state for the epic work they're doing, as well as our healthcare quality and compliance laboratory team. The lift as far as laboratory reporting the last year has been incredible. That said, our state public health lab has done such a phenomenal job. I just want to acknowledge that they were first to publish information on reinfection. They also have been sequencing to look at variants prior to other states. So I truly can't speak highly enough of them. As far as your exact question, though, related to funding, we did give them money off the top for CARES relief funds, for epidemiology and laboratory capacity funds. And so they've been able to purchase equipment necessary. They're also developing capacity in some of our rural communities. Specifically, they've been working with Elko and Churchill County to look at satellite sites. That primarily has to do with shorter transport time for the specimens and quicker turnaround time. So I appreciate them looking at that opportunity again to support our rural communities. Right now, their turnaround time is phenomenal, less than 24 hours. When we were at an excessive number of cases in the states, we did enter into contracts with private labs, including Quest and Charles River and other, to help with that backlog. But right now, our state public health lab is really offering phenomenal turnaround, which is absolutely a necessity for our disease investigation. I'll just speak briefly to the latest epidemiology and laboratory capacity grant. We haven't allocated funds to the state public health lab yet because they wanted the opportunity to hire a consultant to really look at where their lab needs to go in the future. And so they've asked us to hold some funding for them, and they'd like to just hire that consultant to work with them in the future to look at what Nevada needs for the state public health laboratory. So we look forward to doing that with them and then funding them accordingly as much as they need.
And just all the other things that they do, newborn screening, antivirus, like, are they able to keep up with that work while still doing the COVID response?
Julia Peak for the record, they've had no issues. Again, general routine screening unfortunately has gone down. I'd say probably with the exception of newborn screening as babies to continue to get born and get screened. But certainly there's been a decrease in screening for sexual health and other areas, but they've not had a delayed turnaround time in those as well. They've always been really phenomenal with that turnaround time, but the need for it has lessened with COVID.
Great, thank you. Any other questions on this budget committee? Okay, we'll go ahead and move on to 3220, chronic disease.
Lisa Sherrick for the record. Slide 25. Budget 3220, Chronic Disease Program, is focused on creating systems, environments, and policies that help people make healthy choices, reducing economic impact of chronic disease, and enhancing the quality of life to Nevadans. The section has specific focus on improving clinical linkages, statewide health promotion activities, and evaluation and surveillance activities pertaining to chronic disease. Slide 26. Chronic disease is funded primarily with federal grants, other revenue including various transfers, and general fund for Women's Health Connection cancer screening. E900 transfers one health program specialist to the Maternal, Child, and Adolescent Services budget account 3222. E225 funds a gap left by federal restrictions to provide breast cancer screening and diagnostic services to women ages 40 through 49. Assembly Bill 388 from the 2017 legislative session initially approved these funds. This enhancement requests continued funding to support these vitally important services. This funding allows DBPH to offer screening for women who may fall outside of the services provided with the federal funding. According to the most recent Behavioral Risk Factor Surveillance System data, or BRFSS, 66.4% of women in Nevada aged 40 or older had a mammogram within the past 2 years of taking the survey. This is compared to a national average of 71.8%. Slide 27, E226. This request proposes alternate funding for the oral health program. DBPH has developed a strategy to diversify funding from radioactive material license fees to other grants and programs based on the time and effort spent on each activity to reflect a more appropriate cost allocation. As you may recall, DBPH had a letter of intent during the interim to assess permanent and sustainable funding for the oral health program. After much consideration and review, DBPH has developed this final proposal. The Fund for Healthy Nevada revenue will support these efforts. The Maternal and Child Health Program will support services related to non-direct services for children, pregnant, and postpartum residents in Nevada. The State Dental Health Officer will be serving as the clinical consultant for the Medicaid program, as well as the continued efforts to support public health generally. This change will allow Nevada to utilize federal match to support the position while still maintaining similar duties. E491 eliminates revenue and expenditures for the colorectal grant, which has expired. In July 2020, the CDC released a new funding announcement for public health and health systems partnerships to increase colorectal cancer in clinical settings. This grant opportunity did not include funding for direct screening services, but did include continued efforts to sustain evidence-based interventions and other supporting strategies in partnership with health systems to increase colorectal cancer screening rates. Nevada was awarded but not funded. Without funding, we do not have capacity to address these efforts. This concludes the major enhancements in this budget. Does the committee have any questions?
Go ahead and start with Assemblywoman Benitez Thompson.
Thank you so much, Chair Reddy. I appreciate it. So my questions are going to be specific to the Women's Health Connection and the continual funding of that. And so I guess we've had this program in place for a couple of sessions now, and it looks like the funding covers, if I'm correct, an additional 2,100 women in that age group 40 to 49 who can receive the diagnostic, this screening. But generally, could you describe how uninsured or underinsured women can access cancer screening and diagnostic services in Nevada?
Julia Peak for the record. I'd start by saying if they wanted to visit our website or reach out to our agency, we can help them navigate it. Navigation, I would say, is probably one of the hardest things related to accessing services in our healthcare system. We work with Access to Healthcare Network through the Women's Health Connection and many of our other programs, and their main role is navigation. So in some cases, these women may have health insurance and are just struggling to make an appointment with a provider or find a provider. In that case, they don't need to pull on these funds. It's just a matter of navigating the system. In some cases, these women may have access to Medicaid or an Affordable Care Act program that, again, provides the services. If all of that fails, and for some reason these women are unable to have insurance for whatever reason, then we would work, again, with Access to Healthcare Network to get them screened through this program. If those findings came back in the negative, in other words, that it was problematic and it looked like they did have cancer, Access to Healthcare Network, again, would work with them to navigate the healthcare system, perhaps in a discount medical program or otherwise to make sure they get the services needed. So I'll just pause and say I was able to be with you at the table when you presented this bill initially, and so I want to thank you specifically for your support for women's health services over the years, and we've been able to do really good work. And we don't get a lot of general fund in public health, but you were really a champion in this area, and we're very glad that this program has remained.
That was kind. Thank you.
Assemblywoman Titus.
Thank you, Madam Chair. First, I want to acknowledge that in your documentation, you actually included the number of women that have actually received treatment based on this screening tool. And I think that's one of the questions I've asked for the last 4 sessions, is to see outcome data. I mean, did you actually do the test and screen them? So what if you can't get them into a provider? It doesn't really do any good. Now you know they have it, but nobody had treatment. So I'm so pleased to see that about 88% of those women that were diagnosed through this program actually have been involved in treatment. I mean, I think that's really the key. So I want to really thank you for that particular budget item. But then if I might, I have actually some harder questions on the budget E226 on the oral health program. If I might, Madam Chair?
Go ahead.
Thank you. So we've also followed this in this new position of the hygienist and our state dentist. And I see these positions, but I don't really see any data, unlike the treatment data on the last budget. When you reach these folks, the screening, what are these folks doing? Have we really increased access to dental health? Are they really tracking that? I don't expect that the dentist actually sees patients, our state dentist. I don't expect that our dental hygienist goes out and cleans teeth. I think the role was broader. The role was to improve dental access, in my mind, because it is so. We know that dental health is truly a segue to overall health, and that's one of the reasons we authorize these positions. What I'd like to see in here is really, did they make a difference? And I'm wondering what their actual activities were since we've approved them, what their activities are going to be in the future, and what the strategic plan is. And I want to see some hard outcome information on that we've improved dental health here in the state of Nevada. And so could you at least answer that, what their activities were?
Dr. Titus, Julia Peak for the record. So if you don't have that in your notes, it's truly because I didn't provide it to you, but I could say our oral health program, specifically under Dr. Capuro's leadership, has done phenomenal things. I just have open her weekly memo that's 13 pages long of efforts done that week. So I could certainly provide you an overview. And it is everything from actually going in the field to doing screening. So I appreciate that's not her sole duty or the team's sole duty. They have done rural tours and vans and sent pictures of truly horrifying things they were able to address in real time. Again, not the bulk of their activities, but certainly have a lot of data to show what they've done there. As far as more systematic improvements, they've been working really closely with Liberty Dental on a number of things, including partnerships with Medicaid, but I'll say specifically because it's one of my programs with looking at oral health for HIV patients. I've been really proud that they've been able to tackle that. So again, just 13 pages in her weekly report. So I apologize that you didn't have that, but can certainly provide that to you after they've been doing a ton of work with very limited resources.
Great. I think all of us would like to see it. I'm sure the chair, it's up to obviously to the chair's discretion, but I think just how many patients are you seeing and improvement in access and those discrepancies, and even perhaps when we do our statisticians and all, the disparities in not just general healthcare for our folks of color and different backgrounds and lives. I'd like to see some of that dental information also, and access to dental healthcare. I think that's important information we should receive also. So thank you, Madam Chair, for the question.
Thank you for that. I'm just going to go ahead and jump in here real quick, because oral health is something that the Interim Committee on Health has spent a significant amount of time on, and I want to commend Dr. Capuro. Have the reality on the record that we're talking about a very small staff that is trying to talk about all oral health needs across the entire state, and the fact that they're doing any direct practice in addition to trying to do systems change, working with Liberty Dental and Medicaid, is a little bit surprising to me. I'm sure that they are, because they are very dedicated professionals. So the challenge in this budget has been getting to sustainable funding. And so could you just talk a little bit more about the shift in funding and moving away from the radiation piece as the primary source and toward where we're headed in this direction in this budget, to make sure that we do get to keep these staff?
Julia Peak, for the record, thank you, Senator Ratty. And again, I just want to specifically thank you for really championing efforts around oral health in the state. It's been under your leadership, and again, Dr. Capuro's as well. With that said, we did have an LOI as you're well aware, to look at the radiation fees and how we've been funding this program in the past and to develop new strategies. We did look at all of our grants and tried to pull out information related to oral health deliverables. We also looked at other funding streams, again, Fund for Healthy Nevada, our partners at Medicaid and what they could fund for clinical services. And this is what we arrived at. But similar to the cancer registry, we looked at 100 different iterations of how we could potentially fund the program. And this is the one that we feel is the most stable long-term. That said, by no means are we going to stop applying for oral health grants. Dr. Capurro and our team are going to continue to work hard to get those. We do not want to rely on grant funds if we don't have to sustain a program such as this. Again, in the same budget account, we presented how we lost the colorectal cancer screening grant. So when you rely on federal grants like this to do really foundational programs, the loss of that federal funding could be problematic. So that's not what we did here. As you saw, we looked at a number of different funding streams to support the program, specifically the staffing. And then as there are, again, federal grants or programs that need very specific oral health deliverables, we'll work with Dr. Capurro and the team to figure out how we can fund the oral health to do those things. But this, again, looking at Fund for Healthy Nevada, Maternal and Child and Adolescent Health, again, that's been funding this in some capacity. And then our partners at Division of Healthcare Financing and Policy as well. Debbie, did you have anything to add?
Yes, thank you, Julia. For the record, Debbie Reynolds, I just wanted to add that since this is a clinical position, as long as the job duties are aligned and solely benefit the Medicaid program, clinical match of 75% is eligible. Currently, the Division of Public and Behavioral Health is only eligible for a 50% match based on our approved cost allocation plan. So we do believe that this transfer to the Division of Healthcare and Financing and Policy will prove to be a more sustainable model to support the position.
Great, thank you. Assemblywoman or Chair Carlton.
Thank you, Madam Chair. Actually, I have a couple of questions. So if I could go back to the Women's Health Connection, the conversation around that and the navigation part, which has always been really important. You had mentioned that the navigation is through Access to Healthcare Network. Is that basically Northern Nevada or is that statewide?
Julia Peak, for the record, they do offer statewide services, not just for Women's Health Connection, but for other programs as well.
Okay, because I'm not familiar with them in the South at all. I'm not sure if they're even listed on 211 in the South. So I just wanted to make sure that if we're paying them to do a statewide purpose, that people in the South actually know that they exist. And then I can look deeper into the funding for that just to make sure that the funding is appropriate for the work that's being done. On the cervical cancer screenings, has that been, we always tend to focus on the breast cancer screenings. On the cervical cancer screenings, have they been able to get the same level of referrals?
Julia, for the record, I believe we provided that in our talking points. If we did not, I'm happy to provide that to the committee after the meeting, but we do track all of that.
Okay, if you did it in the talking points, then I missed it. So I'll have to go back and look, I guess. So I guess my final questions are going to be towards the colorectal cancer screening services that were provided. There's no other grants available out there. This is very important. And I would hate to see these screening services go away. So there's no other opportunity to screen for this.
Julia Peak, for the record, we too were very disappointed to get awarded, but unfunded for this application. Our team has worked very hard over the years to keep this service, but again, it's a risk with any federal grant. So what we're doing, knowing that we did lose this specific grant funding, colorectal cancer screening, as other preventable cancer screenings, are a service provided through many insurance companies, specifically as it relates to the Affordable Care Act. So again, it's navigating those services. We remain to have the comprehensive cancer grant. And so that systems improvement and navigation will continue to occur. We also have a new 5-year plan that I'm happy to provide the committee looking at cancer services, but we did lose that grant. not due to lack of effort. I'll also note that this unit wrote for a very competitive grant for dementia and Alzheimer's that they did win. And so that's just luck of the draw, unfortunately. My team worked very hard to keep and maintain this grant, but we, again, were awarded but unfunded.
Okay, thank you, Madam Chair. I look forward to getting the answers to my questions.
Thank you. Do we have any other questions on this budget?
Sure.
I'm sorry, Senator Keffer.
Thank you very much. Appreciate it. With the expiration of the colorectal screening grant, we've had that for about a decade, received more than $7 million over the course of that. Is there any sort of comprehensive review of outcomes? Oftentimes, I think when these grants expire, it's a good opportunity to do a look back and see how we did and what the ROI is on some of our expenditures.
Yeah, apologize if there's background noise. Our computer's doing something weird, but no, we do look at outcome. We also look at national screening data related to BRFSS and others to see how we're doing. This specific grant did have specific objectives and deliverables. Again, happy to provide that. Again, with our grant application, if there's opportunity for review, and in 3 or 4 years when that grant becomes available again, we'll apply. But we do have all the statistics on the number of individuals who were screened, the result of that screening, and then the referrals to treatment. So happy to provide that to the committee. Again, we're going to work hard to get that grant in the future, and it was a loss for our state and our program.
Thank you very much.
Thank you, Senator. Any additional questions on this particular budget? All right. We'll go ahead and move on to 3222, Maternal, Child, and Adolescent Health Services.
Lisa Sherrick for the record, slide 28, budget 3222, maternal, child, and adolescent health services supports. Things such as early hearing detection and intervention, universal newborn hearing screening, Title V maternal and child health block grant, child and youth with special health care needs, maternal infant early childhood home visiting program, rape prevention education program, personal responsibility education program, sexual risk avoidance education program, Nevada Alliance for Maternal Health Innovation Program, and Pregnancy Risk Assessment Monitoring System, otherwise known as PRAMS. Slide 29, maternal and child health is funded primarily with federal grants, other transfer revenue, and general fund. E225 requests to convert a contractor position to a state FTE, Health Program Specialist 1 position, to support the maternal and child health section that experiences irregular contract staff turnover and difficulty finding a qualified workforce to address the program implementation needs of serving the children and youth with special health care needs population. E226, this request converts a contractor position to a state 0.5 FTE Health Program Specialist 2 registered nurse to support the Maternal Mortality Review Committee nurse abstractor in Nevada. This position will conduct medical record abstractions, and pregnancy-related deaths will be identified by abstracting and reviewing deaths caused by pregnancy complications and other associated causes to identify modifiable contributing factors and recommend preventative interventions. Slide 30, E550, Early Hearing Detection and Intervention System, otherwise known as EDI. The EDI data is currently entered into the vital records system. OVR is intending to upgrade the current vital records system, and EDI functionality will not be included, which creates the need for a new system to manage Nevada's EDI clients. Of note, EDI functionality is not included in industry popular vital records system software applications and would be an add-on that would be at a price beyond what EDI could sustain. The purpose of the EDI program is to ensure all children in Nevada are screened for hearing loss at birth, and those identified with hearing loss receive timely and appropriate audiological, educational, and medical intervention. E901 transfers the Office of Suicide Prevention to Behavioral Health Wellness and Prevention budget account 3170. This transfer aligns with the Bureau's oversight of the state's behavioral health programs and improves alignment with the mission and vision of the programs. Slide 31, E350, requests a transfer of temporary assistance for needy families, or TANF funds, from the Division of Welfare and Supportive Services to support the Home Visiting Nursing Family Partnership Program. The Nurse Family Partnership, or NFP, TANF pilot will expand an existing NFP program serving the needs of very low-income first-time mothers receiving TANF in both Clark and Nye counties. The TANF funding will add an additional 100 families who will receive the same services as the 50 families currently served by the funded NFP program. The program provides first-time pregnant women from identified priority communities with evidence-based home visiting services and providing delivery of materials and instructions to families in various focus areas, such as maternal and newborn health, family economic self-sufficiency, educational attainment, child injuries, maltreatment, emergency department usage, school readiness and achievement, domestic violence, and coordination and referral to community resources and supports. E680 aligns revenue from general fund to federal funds for replacement equipment. That concludes the major enhancements in this budget. Does the committee have any questions?
Thank you for the presentation. Assemblywoman Monroe Moreno, would you lead us off, please?
Sure. Thank you, Madam Chair. I have questions on, first questions on E350, the TANF pilot program. Currently, there's 50 families, and so with the pilot program, we'll be able to add an additional 100 families. Can you just tell us or explain a little bit more how this Nurse Family Partnership Program differs from other home visit programs that exist, or are they one and the same? And can you explain to us the eligibility criteria for enrollment in the program?
Julia Peak, for the record, I'll go ahead and take this one. Thank you for the question. So the Nurse Family Partnership and the partnership to oversee that program with the TANF program is not new to Nevada. This is a model that other states use. And I'll say specifically this program, as you mentioned, are they all the same? No, there's many different versions of a nurse family partner, of a home visiting program. The Nurse Family Partnership is the longest running and strongest evidence-based program. The reason it aligns really closely with TANF, it has three primary goals that it tracks and that it strives for. The first being to improve health outcomes for mom and baby, but the third specifically is to improve the economic self-sufficiency of families by helping parents develop a vision for their own future, plan future pregnancies, continue their education, and find work. So it's really the other parts of the new mom's life and her family's life to set her up for success. And so related to eligibility, we do have an eligibility criteria. Happy to read it to you, or I can provide it to the committee due to time restraints. With the TANF funding, we've also added that they must be part of the TANF program. That's the only addition that we would have on top of our normal Nurse Family Partnership eligibility. The way these moms come to us, they're first-time moms. And that's another nice thing about this program is we get to the mom and her family early on in her life, so that hopefully, again, we can work on the trajectory of her life and make an impact. As you mentioned, we're going from 50 to 150 with this pilot program, but I just want to say by no means is this going to meet the need that's in the community. When they truly did a needs assessment and have applied for private grants, the need is in the thousands. That said, we're hopeful that with this pilot program, we can show you success with these 150 families and the partnership with TANF, and hopefully ask for more money or promote the program more widely in the future.
Thank you for that, because that was going to be my next question. 150 families seems like a really small number. And my question was going to be just how many families out there could we be helping, and did we have the resources to do that? And so you have definitely answered that question. So I appreciate that. And when you go to E225 and E226 about the two positions, could you just explain to us how the replacement of the contractor positions with permanent state positions and how that will help the agency address its issues with retention?
Excellent question. So we've struggled with this at the division for a long time. We bring on contractors because we are so federally dependent on those funds. In this case, what we put forward in all our budget accounts is for those positions that have truly been with us in a contract for years. In this case, these positions have been with us in 4+ years in a contract position. Clearly, that position is sustainable and needed long-term. I'd say the children and youth with special healthcare needs has been specifically challenging because that population does need stability, and they also need somebody with some historical knowledge of the program and services. And we've had a great deal of turnover, not at the fault of the program or the staffing. If a permanent FTE position opens up, then by all means should that individual apply and get health benefits and state benefits. So it's been a true challenge with recruitment and retention. Again, this has proven that it has to be a sustainable position. The next one, same argument, except that the Maternal Mortality Review Committee is newer to our programs, but based on the work they've done to date and the need for that program in the future, we're going to use our State Systems Development Initiative grants, again, one of those that we're moving from 30 to 19, and allow that to support the program in perpetuity, or again, as long as we have that grant, and that grant has been in place for many, many years. So I see no reason that we would lose that. So it's truly just a reflection of what the division thinks will be a long-standing FTE and program. And so we're requesting that you consider allowing us to just make that an FTE.
Well, I was very happy to hear in the explanation overview of these positions that one of those positions will be supporting the MMRC for data collection. And that was one of the main reasons to have the MMRC is for data collection. So I appreciate putting a position there that can focus on the data, especially the data that that impacts our communities of color the most, because that was one of the big pushes for the MMRC. So I'm happy to see that you're looking to put resources there. So thank you, Madam Chair. I have no other questions.
Thank you, Assemblywoman. I'm also excited about that. We'll go on to Assemblywoman Tolles.
Thank you so much, Chair. And I believe Assemblywoman Moreno touched on a lot of the questions that I had, but I am interested in that eligibility piece in terms of how we use those TANF funds, because I know that we've had questions in a prior meeting around the reserves that are still available and how those might be utilized to perhaps expand this program as well as apply to other early intervention and so forth programs. So I'll just be looking for that information that you share, and unless you want to add anything to that response.
Julia Peak for the record. I speak incredibly fast, so I'll just go ahead and read you the eligibility criteria because I think it is important. First-time mom before 28 weeks of program entry, and she must meet the home visiting qualifications, including a low-income household. Household contains an enrollee who is pregnant and under the age of 21. Household has a history of child abuse or neglect or has interactions with child welfare. Household has a history of substance abuse or needs substance abuse treatment. Someone in the household used tobacco products in the home. Someone in the household has attained low student achievement or has a child with low student achievement. Household has a child with developmental delays or disabilities. Household includes individuals who are serving or formerly served in the U.S. Armed Forces. And again, with the TANF pilot, these individuals also must be enrolled in a TANF program. So that's how the individual is going to join our program. As I mentioned earlier, unfortunately, 150 is just a small amount of effort as this need is large in the thousands. So we're going to work really closely with our social service entities as we bring these people into the program and hope we can grow it in the future.
Thank you. Follow up, Chair?
Please go ahead.
So I appreciate that in regards to eligibility for the participants and what qualifies them to participate in this program. I think my broader question is just what are the restrictions around the use of TANF funds, and again tying it back to that reserve that we have, and could we perhaps tap in, because we had talked about how there was approximately 16 million that was untapped, potentially left over in reserves, and versus the 90 days that we're required to keep into the bank, and just wondering if there's restrictions around how to use those TANF funds for this program and other programs, and that may be a conversation offline.
Yeah. Thank you, Debbie Reynolds, for the record. The TANF funds are within the Division of Welfare and Supportive Services. So unfortunately, I don't have the information regarding the restrictions for the use of the funds, and I'm not able to speak to their level of reserve.
Thank you. Appreciate that.
An ongoing conversation about the TANF reserve, and we'll continue to dig into that. Senator Kiekefer.
Thank you, Madam Chair. I got to back up one budget really quick. Ms. Peak, you referenced when we were talking about I think it was the chronic disease budget, a document called, that you referred to as talking points. And I don't know exactly what you were referring to. It seemed to have some more information in it. Can you point me to which document you provided that you were referencing?
My apologies, Julia Peak for the record. I was referring to the questions we get from the LCB staff. They ask actually extremely good detailed questions and we provide answers. I believe we provided that level of detail in those answers, but can certainly follow up. Refer to them as talking points in error, but it is those questions and answers from your team.
All right, that's what I was assuming there were, but I just wasn't sure if there was something posted on Nellis that I was missing. Appreciate it. Thank you.
Assemblywoman Titus.
Thank you, Madam Chair. On the same budget, the E350 and then into the E225, we're talking about the Nurse Family Partnership Program. You're going to expand it to 150 families, and that budget or TANF is going to be $848,000 to expand that program to an additional 100 families. So the total for that money would be 150 families. Is that correct, that you're trying to reach?
Yeah, Peak, for the record, you're correct. 50 current under the Nurse Family Partnership Program. In that program in Clark County, we're requesting to use the TANF funds for an additional 100 for a total of 150 families.
But those two new contractor positions and that you're changing to permanent positions, they're not going to be actually the folks going into the homes. They're the data people. They're the ones that are going to keeping track of that. Is that what their role is going to be?
Julia Peak for the record. Sorry if that was confusing. They're actually not associated. So we have the Nurse Family Partnership Home Visiting, which is a program under the Maternal and Child Health Adolescent Program. We also have the Children and Youth with Special Healthcare Needs Program, which is a different program. Of course, they all work together in the same unit, but Maternal Mortality Review Program is a program within Maternal and Child Health, but these specific positions aren't associated with that specific item.
Do you have any idea how many people will be employed or that you will need for the additional 100 people under the Maternal, Child, Adolescent, family home services? How many additional personnel will you have to hire for that?
Julia Peak, for the record, I don't have that number in front of me, but it's very easily pulled out of the sub-award we currently give to the agency. So if I could follow up with that after the hearing, it'd be easy to provide at that point.
Very good. So let's go back then to the two positions, the contract people that you're now moving over to two state permanent positions. I touched on this earlier about all these new folks that you're now hiring to state positions. You're bringing them in at their grade 35. You're bringing them in at a step 7. And then there's a grade 37 and you're bringing that person in at a step 7, which there's cost to the state for that. There's nobody within the department you can move up and then fill that person at a lower grade.
Debbie Reynolds for the record. Again, the step 7 for the Health Program Specialist 1 and the Health Program Specialist 2, it was built into the budget as a tool to allow sufficient authority to hire the positions. Actually, the incumbent selected would be, the steps selected would be dependent upon the qualifications of the existing candidates. So it's not a guarantee that they would be hired at the level that's budgeted.
So the person that's currently the contract person will have to go through the actual process and applications to fill that position?
Thank you. Debbie Reynolds for the record. That's correct. It's not a guarantee that the contract position would automatically be moved into the state position. We would recruit for the position and they would have an opportunity to apply and interview for the position.
Great. Thank you for that clarity. Thank you, Madam Chair.
But do I have any additional questions on this particular budget? All right, we'll go ahead and move on to 3223, Office of Health Administration.
Lisa Sherrick for the record, slide 32, budget 3223. The Office of Health Administration oversees the enforcement of all laws and regulations pertaining to public and behavioral health, along with ensuring adequate services are provided for persons with mental illness, substance abuse disorders, co-occurring disorders, and other related conditions. The office also supports the State Board of Health and the Commission on Behavioral Health. Slide 33. The Office of Health Administration is primarily funded with indirect and cost allocation revenue, with a small amount of general fund to support poison control services and the MammoVan. We are requesting a cost allocation redistribution to remove general fund in the administrative accounts and fund the full cost allocation into the behavioral health accounts. For transparency, general fund will be removed from the administrative account and budgeted in the behavioral health accounts, and then transferred to the administrative account through cost allocation. Slide 34, E900 transfers the Public Information Officer from the Public Health Preparedness Budget 3218 to the Office of State Health Admin Budget 3223 to better align the duties of the position. Though this position was initially funded to communicate on public health emergencies and threats, there is a much greater need for public health communications across the division from all programs. This position reviews all documents and reports that are shared publicly across all programs. And additionally, this position supports all Freedom of Information Act requests, as well as subpoena or legal requests on behalf of the division. E380 funds an increase in conference call charges due to operating remotely during COVID-19. As with all other businesses, DVPH has experienced a much greater demand for remote and virtual services during COVID. These tools have proven to be the cornerstone that has enabled the continuity of our agency, even with the change to telework for many of the public health programs. That concludes the major enhancements in this budget. Does the committee have any questions?
I'm going to ask Assemblyman Watts to lead off.
Yes, thank you, Madam Chair. First, could you just explain in a little bit more detail the recommended shift in funding from general fund to cost allocation revenues?
Thank you. Debbie Reynolds for the record. Prior to state fiscal year 14, the Mental Health and Developmental Services Division and the Nevada State Health Division were two separate divisions. During that fiscal year, we merged into one division and became the Division of Public and Behavioral Health Services. With that, brought together two large agencies. On the public health side, we collect indirect based on all of the eligible expenditures on the federal side for the various federal grants we have to support public health programs. On the behavioral health side, there's a cost allocation plan, which allocates administrative support across the division based on that plan. At the time that we merged, the cost allocation that was budgeted for the behavioral health programs was based really only on the Medicaid portion of revenue within the behavioral health budgets. And so it was really just a percentage of the revenue to the overall budget. And then the rest of the budget was just general fund that we had in the account. So for transparency, we're requesting to remove the general fund in the administrative account and instead budget it in the behavioral health accounts. And then it would be transferred to the administrative budget to support the overall administrative costs. It really is, it's for transparency to show that the true allocation of administrative support across the division.
Thank you. I know you had mentioned the increased transparency in your initial presentation, but I appreciate the additional background. The other question that I had is just around the reserve levels, and can you explain what are some of the contributing factors to the declining reserves over the upcoming biennium in this budget?
Certainly. Thank you for the question. Debbie Reynolds for the record. The minimum reserve level in this budget account is based on 90 days of expenditures. Based on this assessment, the reserve level should be approximately $1.1 million. The reserve has been depleting in the base budget due to accounting for salary increases each year and additional positions that were added to the budget over the 2021 biennium. There's a 2-year delay in receipt of indirect revenues. Annually, we submit our indirect cost rate proposal to the feds, and it takes about a year to get approval of those rates. For example, we submitted our FY20 proposal based on 19 actuals in December of 19, and we still have not received approval of those rates, likely due to the delay in COVID. That said, we have been in communication with our federal negotiator, and we do expect approval within the next 3 to 4 weeks. Based on the 3-year average of direct costs, we do anticipate those rates will be increasing, and we believe that we're going to be generating additional indirect revenue. Additionally, when the budget was balanced, an error was made. Revenues need to be adjusted to match the maximum revenue projected in the budget. And there's also a transfer that remained that needs to be removed. We believe that with these adjustments, accounting for the new indirect rates approved in the near future, that this budget account will not resolve insolvency issues.
Great. Thank you for the additional information, and thank you, Chair, for the questions.
You bet. Senator Hammond, are you trying to get my attention? I can't tell from your hand gestures if you're trying to get me or...
Nope, I'm not trying to get you. Sorry about that. I'll put my other hand up. I'm just dancing. I'm sorry.
That's okay. All right, does anybody else have any additional questions on this budget? All right, let's go ahead and move on to 3224, Community Health Services.
Slide 35, Lisa Sherrick for the record. Budget 3224, Community Health Services, or CHS, otherwise known as the Community Health Nursing, serves as a safety net resource with the primary focus of serving low-income and underinsured or uninsured populations in underserved geographic areas. The CHS staff identify needs and work to fill the healthcare gaps in their communities. Counties served include Lyon, Churchill, Mineral, Humboldt, Pershing, White Pine, Nye, Lincoln, Elko, Esmeralda, Lander, and Eureka. Slide 36, community health nursing is primarily funded with general fund and other revenue, including fees related to family planning services, general health screenings, checkups, and vaccinations. Other revenue also includes county participation funds and various transfers. Federal revenue includes the Family Program Grant. E901 transfers 1 health resource analyst FTE to Public Health Preparedness Budget 3218 to better align the duties of the current position. E680 maintains 2 community health nurse FTEs vacant through FY 2022. In order to ensure services occur in all contracted counties, DBPH is using a traveling nurse model to cover the counties and are assessing using contract nurses to support the identified needs. DBPH will assess if grant funds are appropriate for the services and can move forward accordingly. Slide 37, E681 maintains 1 Administrative Assistant 1 FTE vacant through FY 2022. E682 aligns revenue from general fund to federal funds for replacement equipment. That concludes the major enhancements in this budget. Does the committee have any questions?
Assemblywoman Titus.
Thank you, Chair Ratty. I have questions and big concerns over this budget and the leaving these positions vacant. Could you tell me how you, as you state early on in your comments, this is like sometimes the only critical access to any preventative health care, public health services in these communities. And you currently have them filled with contract nurses. Is that what I heard you say?
Julia Peak for the record, it's really a combination, Dr. Titus, and I don't disagree with anything you say. They are a safety net, as we noted. So we chose these 2 positions simply because they had been vacant for the course of a year. As you can appreciate, it's really hard to recruit for positions. So we will really take nurses in whatever form that they're willing to come to us. And in some cases, they want to work on a contractual basis because perhaps they have a different full-time job and this is in addition to that. In some cases, they do want an FTE position, and that's why we held the positions vacant. Again, general fund, with those cuts, those were the easiest, but that certainly isn't a reflection of a lack of need in those communities. I'll note just specifically related to COVID, because I think it's important, we pulled out the rural counties and gave them their own per capita allocations for both epidemiology and vaccination services, and they're working on those budgets now. So they're looking now at a model to either hire nurses locally or hire a private company. Again, private companies can come to the county and provide those services locally, at least as it relates to COVID, or to build on our community health nursing program to hire the staffing as needed. So perhaps we'll use it as an FTE position, perhaps we'll hire contractors, perhaps we'll use a third-party vendor. It truly is whatever meets the needs of the community. And again, if we were to get a different source of funding, we left them vacant so we could come forward and present that to you at IFC and hopefully get those funded with a different allocation. The need remains. Even in addition to these two positions, the need remains across the state for primary care and safety net providers.
Great, thank you. Obviously, I agree with what you're saying as far as the need. One of my concerns also is the use of the vaccines. We know that a place like Tonopah that does not have a healthcare facility now, that home health nurse may be the only place they can get that vaccine. The cost of the vaccines, we know they can't in Fernley. I know there's a CVS pharmacy, et cetera. They could walk in there. There's a Rayleigh's that could walk in there and get their vaccines. Problem is, those usually require some resources. And so that community health provider is critical not only for family planning, but now for, as we've seen, our lower rates of vaccination, wanting to make sure that these positions weren't going to be permanently eliminated, that I want assurance from you that you're going to continue to look at whatever solution it takes, whether it's contract or whatever, to make sure these positions get filled in some capacity, because that access to care that we continue to talk about in these other budget, and especially now talking about vaccines, that's frequently the only place they get these vaccines. So anxious to hear further discussion along the line when you come down to that, because I just worry about the services provided in the rural areas and the lack thereof, and just what's going to happen to these communities in general, Fernley and Tonopah. So thank you.
Julia Peak for the record. I'll just touch on a couple things because I think they're important. We do have a hire packet in for an RN to be in Tonopah. So we're moving the Hawthorne nurse to Tonopah. So hopefully we understand that's an area of huge need. And so we're able to move the positions based on recruitment and where the individual wants to live. So totally understand in that specific area. Also, I want to note we're looking for vaccination at opportunities to partner with home health agencies, and then also those agencies that are already going to individuals' homes, senior meal programs. How can we partner with them to get vaccination in the home setting? The other thing that's an allowable expense, and we're absolutely looking at in the epidemiology and laboratory capacity grant, they encourage the use of mobile units. Again, those mobile units can go deployed at anywhere in an urban area where we're seeing low vaccination rates, or in a rural area where it's problematic for the individuals to travel a great distance. Also going to be great value when we get a single dose shot, such as the Johnson & Johnson one, if we go out to a site and have the opportunity to give a vaccination once, because the dual vaccination is complicated. Once we make these investments for mobile units and others with the COVID funds, is again, we're trying to do as much as we can to build the infrastructure of public health at this unique crisis opportunity. And so not to divert too much, but we're improving our public health laboratory reporting systems, infectious disease reporting systems, again, outreach and response in rural and underserved areas. So we're not passing up the opportunity to use these funds to improve a number of different areas. So I look forward to presenting to you all on the success of these programs. We're just, again, working with the counties on how to implement based on that CDC grant.
Great, thank you, Madam Chair, and Ms. Peak. I have you on speed dial, so I'll be interesting to follow up on what those are. So thank you for what you're trying to do there. Thank you.
Any additional questions from the committee? believe that is our final budget for the day. Want to commend the staff from the Department of Public and Behavioral Health that was a lot of information. Did a very nice job of quickly reviewing each budget and hitting the highlights for us so that we could get to questions. So thank you so much for your comprehensiveness, but your efficiency today. We appreciate it. Last call for questions. Not seeing any. All right, so then we're going to go ahead and pause for a minute and ask BPS to hear a public comment for us.
Chair, this is Michael from Broadcast. I potentially have a couple callers already. Would you like me to go ahead with those?
Please do.
Caller with the last three digits, 120. Please slowly state and spell your name for the record. You will have 2 minutes and may begin. Caller with the last three digits, 120. Please slowly state and spell your name for the record. You will have 2 minutes and may begin. Caller with the last three digits, 200. Please slowly state and spell your name for the record. You will have 2 minutes and may begin. Caller with the last three digits, 200. Please slowly state and spell your name for the record. You will have 2 minutes and may begin. Caller with the last three digits, 350. Please slowly state and spell your name. You will have 2 minutes and may begin. Caller with the last three digits, 350. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good morning. John Bilstein, Jon. Last name is Bilstein. Thank you, Chair Ratty and members of the Senate Committee on Finance and members of the Assembly Committee on Ways and Means. My name is John Bilstein, and I am the Chief Executive Officer for Comprehensive Cancer Centers in Nevada. As background, Comprehensive is an award-winning multidisciplinary oncology group comprising medical oncology, hematology, radiation, breast surgery, and pulmonary medicine. Our practice is community-based. We are physician-led and owned, and we do treat more than 13,000 new patients annually and a little over 375,000 office visits per year in our 15 locations across Southern Nevada. Since 2017, we've had several conversations with Ms. Julia Peak, Deputy Administrator for Division of Public and Behavioral Health and the Nevada Central Cancer Registry, and came to an agreement that we would begin submitting our data to the registry, even though there was an understanding of statute NRS 457.057 that we potentially were exempt. In good faith, however, Comprehensive has worked with the NCCR and department in providing data for the cancer registry. We are the largest provider in Southern Nevada, and we understand that the data we submit to NCCR is extremely beneficial to the state. On January 3rd of 2020, we received a letter regarding the technical bulletin from DPH on basically a fee of $250 that would be assessed per patient diagnosed with cancer submitted to the NCCR. Since then, we've had several conversations with Ms. Peak and the department, and we believe the changes proposed today are a better alternative that we can support. We're comfortable with the proposal to add a fee of not more than 8% for the registration and renewal of radiation machines, mammography, healthcare facilities, and medical laboratory to support the registry. This is clearly a better alternative to the $250 fee assessed, per patient diagnosed than what was originally proposed a year ago. So we are supportive of adding additional language that would give the registry authority to approve and enforce cancer reporting. As I mentioned in my beginning testimony, we will continue to report in good faith. We will continue to treat all the patients in Southern Nevada. We'll continue to work with the Department of Public and Behavioral Health and to maximize efficiency of reporting while minimizing any burden on other practices, both of which we believe can be achieved while fulfilling the intent of the comprehensive registry. Again, we thank you and we do support this alternative that was proposed today.
Thank you.
Caller with the last three digits, 044. Please slowly state and spell your name for the record. You will have 2 minutes and may begin. You can press *6 to unmute. Caller with the last three digits, 044. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Dr. Tiffany Tyler Garner, TYLER-GARNER. Good morning, esteemed chair and members. My name is Dr. Tiffany Tyler Garner, calling in support on behalf of Children's Advocacy Alliance. I want to specifically commend and thank the department for its service, and in particular, its commitment to the home visiting pilot. The Nurse Family Partnership is a nationally recognized evidence-based program providing critical prevention services at a time when they are needed more than ever. As we look at the resources that can be afforded families to thwart things like child abuse or the critical need to ensure healthcare access during this public health crisis, we couldn't be more pleased and thankful that they are thinking forward in terms of ensuring that families are girded with these critical prevention services and supports. Thank you.
Hello, caller with the last three digits, 200. Please slowly state and spell your name for the record. You will have 2 minutes and may begin. Press *6 to unmute. Caller with the last three digits, 200. Please press *6 to unmute.
Hi, am I unmuted?
Yes, you are. Please go ahead. Again, it's *6 to unmute.
Hi, am I unmuted now?
You are. Please go ahead.
Okay, thank you. Sorry about that.
That's okay.
Good morning, Bradley Mayer, for the record. BradleyMayer. I'm a partner with our Jensen Partners representing the Southern Nevada Health District today. And we just wanted to highlight as a means of providing some information that this chronic disease budget has eliminated the tobacco prevention funds from SB 263 last session. And SB 263 created taxation of alternative nicotine products and vapor products as tobacco products. This reclassification alone has brought in millions in extra revenue to the state per year. SB 263 allocated $2.5 million per year to fund tobacco control programs with a goal to address Nevada's youth vaping epidemic, as 1 out of 5 teens are currently vaping. Our efforts to combat this youth vaping epidemic were having an impact as the campaign has reached approximately 125,000 teens to date, and we saw a 20% decrease pre-pandemic in violations for retailers selling vaping products to minors. So we acknowledge that we have a budget hole to fill and that there are always more priorities than money every session. However, we would encourage restoring some portion or all of this funding should funds become available down the line, and I thank you for your time.
Thank you.
Caller with the last three digits, 670. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Good morning. For the record, my name is Carrie Harrington. That is spelled CARIHERINGTON. I'm the director with Nevada Cancer Coalition, and today I'm representing our partners across the state. And I have 3 items to address. First off, we strongly support the enhancements to the Nevada Central Cancer Registry budget. Ensuring both the quantity and quality of our registry data is critical for health officials and medical professionals in both addressing cancer across the state and also in making informed public health decisions. So strongly support restoring funds to the youth vaping prevention activities established last session through SB 263. As a state, we've already made a major investment in this effort, and we're seeing success, as the previous caller had mentioned. To stop funding this now would be a true travesty for our teens. And finally, I had submitted a letter on this. We respectfully request state funding for colorectal cancer screening and diagnosis for underserved. Colorectal cancer remains the second leading cause of cancer deaths in our state. As Ms. Peak shared earlier, the CDC has long recognized our state's excellent work in colorectal cancer prevention, and for the past 10 years, they've funded our state with screening and diagnostic dollars. In fact, we were just one of 5 states that had received this funding most recently. Unfortunately, as you heard, the CDC funds are no longer available, and that's why we need state funding to fill this gap. Our state has managed a very successful and life-saving colorectal cancer program in partnership with Access to Healthcare Network, which in the past 5 years alone served almost 3,000 underinsured and uninsured people who did not qualify for Medicaid. While 6 cancer diagnoses were made, 213 people also had dangerous polyps diagnosed during a routine screening thanks to this program, and that most likely prevented cancer for them and saved lives. We know how to screen Nevada's underserved, and we have a track record for efficiently and effectively saving lives. Our communities are currently struggling to fill this gap in funding, so the state funding would allow us to continue these efforts. Thank you very much.
Thank you.
Call with the last 3 digits, 672. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Good morning. This is Joelle Gutman Dodson, JoelleGutman-Dodson, calling today representing the Washoe County Health District. And I just wanted to follow up with a letter we submitted in exhibits yesterday. The bill from last session, SB 263, awarded the Washoe County Health District more than $400,000 during last biennium to implement youth vaping prevention activities. And these activities did a lot for prevention and education around youth vaping. Unfortunately, that funding was zeroed out this biennium, and without adequate funding, these youth vaping prevention activities and the infrastructure and capacity gained will be significantly reduced. This will result in more youth use of nicotine products and the subsequent impacts of nicotine addiction and health risks. So we are asking the committee to really look at budget item 3220, particularly for tobacco prevention. Thank you.
Thank you.
Caller with the last 3 digits, 120. Please slowly state and spell your name for the record. You will have 2 minutes and may begin. Please press *6 to unmute. Caller 120, you are unmuted. Please go ahead. Caller, is your phone itself muted? We can't hear you on the call.
Oh, my apologies. I forgot to unmute. My question is, are we in public comment yet?
You are in public comment, and you have, please slowly state and spell your name for the record. You will have 2 minutes, and you can begin now.
Okay. Good morning, Madam Chair, members of the committee. Stephen Cohen for the record. I'll keep it nice and short and sweet. Stephen with a V, Cohen as in the Assemblywoman. I wanted to address budget account 3213. Currently in the South, prioritization lanes are being interpreted only for mobility disabilities, and would like to work with the immunization folks to ensure that intellectual and developmental folks are not left behind. I am already on the notification list, so just patiently waiting. And with that, Madam Chair, thank you, and I yield.
Chair, this is Michael from Broadcast. The public comment line is open and working. However, we have no more callers at this time.
Okay, thank you. So I'm going to thank everybody on the committee for their good questions and their efficiency, and we'll go ahead and adjourn. Thank you so much.